Welcome to the Leavitt Group webinar, Annual Compliance Review. Today we were talking about the new items that we have found coming out this year and new things for next year. Before we begin, just to let you know, we are recording this presentation now. This recording, along with slides and supplemental educational materials, as well as some templates, we'll provide that to you in the next day or two. We'll send you out an email that has all of that. Feel free to type in questions in the chat feature. I will stop throughout and take a little peek at that and see if there's any questions. I'll also stop and just open up the phone line for questions at some points as well. So feel free to ask questions. I don't mind the interruptions. It keeps me interested while I'm talking at you guys today too. If you have any questions after our time here today, feel free to reach out to your trusted Leavitt Group advisor. We're here for you. I'm a member of their team, so I'm by extension a member of your team. So we have a lot of resources for you, including me. So if you have other questions, feel free to reach out to them. On our agenda today, in addition to the ones I've already mentioned on the prior slide, we're going to be also talking about pharmacy transparency. Like I said, there's a lot of transparency that we're talking about. We're going to talk a little bit more about long-term care and some trends we're seeing there, as well as this new gag clause attestation. I'm sure some of you have been receiving some things from your carriers or others about a gag clause attestation that's required to be submitted by December 31st. So we're going to talk a little bit about that as well. So all of the hot items that are happening right now for you to be aware of, to let you know so we don't forget any of them. So let's talk a tiny bit about Affordable Care Act, also called the ACA. Some of you may recall this was passed as part of the Obamacare, they called it back then. There are a lot of limits and provisions in the Affordable Care Act. So I'm only mentioning this one small, narrow one, and that's affordability. This changes every year, and every year health insurance gets more expensive for our clients. So it has adjusted again to 8.39% of one of the safe harbors. So in order to calculate affordability, that premium portion for the employee cannot be more than 8.39% of one of the three safe harbors. You can either choose federal poverty level, their W-2, or their hourly rate. Wage. So you can choose which one of those three you want to use and then use that 8.39% to determine if it's affordable. Using the federal poverty level, which is the most expensive for employers, but safest one because you can apply that to everyone regardless of their pay, but just means you're paying more for some. That will be putting you at $101.94 a month. So that employee couldn't be paying more than that per month for their medical coverage. The federal poverty level changes every year, but a little too late for us. So you can use the 2023 federal poverty level for the first 6 months of 2024 as well. So once those are released, then you would start going off of the 2024 poverty level, but that won't be released until 2024 usually at the beginning. So penalties as well have changed. So we also have an article on this. It's linked there, but I want to sort of make sure you notice that I link a lot of things in my presentations. These are all active links. So once you get the presentations after our call today, you can just click on them and it'll go right there. So we write a lot about this. I wrote more about it in our news.leavitt sites. So also in addition to the change in affordability percentage, we also had a change in the penalties. So we have A penalty and B penalty. So for those of you that aren't familiar, if you're not offering minimal essential minimum value coverage to your full-time employees, that's your A penalty. You have not offered coverage. B penalty is if you've offered, but it's unaffordable. So you can be offering the sufficient plan, but you've not met this affordability percentage of 8.39% in 2024. And then the trigger would be, if you're in the B category, your trigger is one of those employees found the coverage to be unaffordable for them, and they went over to the marketplace exchange. They qualified for a subsidy to get coverage there, and then now you've triggered a penalty because you had one employee get subsidized care. At that time, the government will come back to you, IRS will come back to you and say that you owe them a penalty for not offering that person affordable, sufficient coverage. There's a whole process in these letter 22J letters. So there's a whole big process to that. I'm not going to bog you down with that today. We could spend an entire day on ACA actually. So just be aware that there's a process to it. We do help our clients a lot with that. So if you do get a letter 226J letter from the IRS, and you're wondering what to do and you're feeling overwhelmed, reach out to us. That's something that I can help you with as well. We'll walk you through the process. Sometimes it's just a matter of bad calculating on the government side, or or the employee maybe fibbed a little in order to get that subsidy. So you can iron that out sometimes through the process. So there's your little update on the Affordable Care Act. We do have a calculator, which you might have just saw a little peek to. So that bottom little section on your slide here is just part of the bigger calculator that we've built out. So if you need to calculate things like your measurement period, affordability, your PCORI fee, all of these important ACA requirements, we have calculators for them. So you don't have to, I know if you're like me, you're sitting with your calculator trying to figure things out. Sometimes it can be a little much. If I was good at numbers, I'd be a medical doctor and not a juris doctor, I'd say. But there is a bigger calculator available to you. So ask your Leavitt Group trusted advisor for that if you would like access to the calculators that we have. Next up is the No Surprises Act, which is funny because I like to call it the Surprise Act because some people just didn't know what was happening at the time. So No Surprises Surprise Act. We don't really hear much about it right now, frankly. So I don't talk a whole lot about No Surprises Act because it really impacts mostly self-funded plans who are more involved in their claims adjudication than what we normally see. So the No Surprises Act was passed in 2021, or actually it was just before that. The rules came out in July of 2021, and it generally prohibits balance billing. So a participant can't go be charged whatever's left over from the carrier not paying the whole claim. You can't do that for emergency services that were provided out of network to no fault of the participant, because you don't really have a choice a lot of times when you go to the emergency room for things. Some of those providers might be out of network for you, but you don't have an option in using them. You're in an emergency situation. So in short, it's taking away that burden of balance billing mostly around emergency services. So let's talk a little bit more about it. So under the No Surprises Act, so cost sharing for out-of-network emergency services and some of the items and services for some of the goods and services cannot be greater than what it would have been if they were in network. So basically, in network for out-of-network emergency services is the rule. And there are some general, it's more complicated than that. So what would happen is the provider, let's say the hospital who treated the individual, the plan participant, had out-of-network providers. They sent a bill to the insurance carrier or the TPA who said, we're not going to pay this full amount. We can't balance bill the participant because of the No Surprises Act. So then the provider and the plan enter into a dispute resolution. We'll talk more about this in a second, in the next slide. But then there's sort of a negotiation process that was built into this law that has been kicked around a little bit. So I'll talk about this one in the next slide. But what I really want you to understand in this slide is that this applied to air ambulances as well, which is very, very expensive, as we all know. And along with the Air Ambulance No Surprises Act, no balance billing portion, is there's a new reporting feature as well. So Air Ambulance data collection, it will be called, it will be submitted through the CMS website, and the plan, which will largely be carriers and TPAs, would then be required to submit that data to CMS so that they can monitor and probably come up with additional regulations around the cost of air ambulances. So this was supposed to happen this year, actually by March. It kept getting kicked down the road. And now the regulators have said, definitely not 2023. So look for in 2024. We'll let you know when that happens. We always write on this. So we have a couple of articles we've already written on this. So if you're not subscribed to the news.leavitt.com site, I highly recommend you do that. That's how I communicate with you throughout the year of important things happening. So it's not going to happen this year. I'll let you know next year when that happens. We'll have additional education on that coming out. I've also included some links if you want additional education around the No Surprises Act as well. But you can read our articles, those are summary enough. Now, I mentioned that there has been this other part. So you have the part of No Surprises Act, which is we can't balance bill. Provider who's out of network maybe, and plan, you guys figure it out, because we're not balance billing the plan participant. And that figuring it out process is called the independent dispute resolution process. And originally it was $50. And so the resolution expert, so a mediator type of person, right? $50 to engage in the process. It would be for each claim. So it can get priced even at $50. And then last year that went up to $350 administration fee. There was a lawsuit in Texas, and then that part was actually vacated and thrown out. So now we've gone back to $50, and it's likely going to be modified again. So there's a little bit of bulkiness happening. It probably won't impact most of you because, like I said in the beginning of this discussion, I don't hear a lot about No Surprises Act. I don't hear a lot of our clients engaging with the independent dispute resolution. I think that's mostly because that's really resting with the carrier and TPA to do the heavy lifting then. The portal for opening a dispute resolution was just opened earlier this month. They had shut it down because of this court challenge and it being sort of thrown out and then not really knowing what to do with it. So it is open again. You could go there. But again, if you have any questions on the details, I don't want to get into weeds in something that most people don't care about. And I'm not saying you don't care about it, but if you do care about it, let's reach out to your trusted advisor and we can offline in more detail about how this impacts you. The blue link there is to the new portal, by the way, and it has some information on that page about what happened in this court case. So it's always an interesting look if you're interested in seeing what's happening on that particular provision. Mental health parity, we're going to spend a little bit of time on. So mental health parity has been around for a while. I want to say, what was it, in the early 2000s? I'm trying to remember. Let me go back that far. But since 2020, there has been increased oversight in the area of mental health parity. Under Mental Health Parity Addiction Equity Act, both self-insured and insured plans, mainly via the carrier the carrier themselves and the TPAs themselves, they must ensure parity, which means they're on par, right? They don't have to be identical. They have to be close. They don't have to be exactly identical because they aren't the same. Sometimes it's hard to be identical, but they have to be similar, very close to the same. And that must be parity when we're looking at financial requirements, so your deductibles and copays, and your treatment limitations. So if you have step therapy programs or pre-authorization or any category like that, that's also needs to be on par. If you don't have a pre-authorization for, let's say, a rehab for your surgical injury, then you shouldn't have that for a mental health substance use one either. So that won't usually happen because even with the leg surgery, you get a referral for that. But that's just to give you maybe a poor example. So there are two categories that we look at. We look at numerical or quantitative. Those are your quantitative treatment limitations. And then the other ones we talked about, your non-numerical treatment limits, your step therapy, your prior authorizations, and other things like that. Plans are prohibited from having more non-quantitative treatment limits on mental health substance use than on medical surgical, but we kind of see that there a lot, which is why we're seeing the regulators pay a lot of attention right now to mental health parity. They're increasing oversight year after year, auditing more and more year after year. I think we're all used to seeing it in just the world right now, a lot of talk about mental health. And so this kind of goes along with that as well. So you can have any, in applying those non-quantitative treatment limitations, those non-numerical, the plan terms and operations use processes and strategies, evidentiary standards, or other factors that are comparable to or applied no more restrictively, no more stringently than those on the medical surgical side. So parity as much as possible. So the parity, we're looking at these 6 categories specifically. So inpatient, in-network, inpatient, outpatient, in-network, outpatient, prescription, and emergency. So each one of those categories, when you're looking at parity, has to examine each one of those separately to determine if you have some out-of-network copay that is higher for mental health than it is for medical surgical, for example. So if you're outpatient, copay is $25 for medical surgical, it better be that for mental health parity. If you have formularies in your prescription drug plan that are more restrictive or don't include more of the mental health drugs, then on the other side, that could also be a non-parity issue that could cause some non-compliance. So the reason why we really want to drive this one home, I'm talking a lot about this one, especially since 2020, but I feel like this year I've been really trying to pound it in because we're just seeing a lot of auditing, a lot of concern in this area. And that's because since 2020, there's this self-compliance tool that has been put out by the Department of Labor. They say this is required, but initially there was no real oversight. So eventually up till today, we have penalties and audits and congressional reports. So when conducting your mental health parity audits, lean heavily on your TPA and carriers and PBMs. They are the ones who do this more than you. We as plan sponsors sometimes aren't sitting in the room trying to figure out what do we want a step therapy, why we want step therapy, how is the step therapy permissible in this, but maybe not needed in the medical surgical. That entire analysis, we don't typically have the benefits person at a company doing. Sometimes, but not usually. So we really want to lean on the carriers and TPAs to complete this requirement, to do this audit for you. You can contract with your self-funded TPA or PBM or your insured carriers to do this for you. Like with most of the compliance requirements that say that, the self-funded plan can never get out of liability. So we can transfer liability as a fully insured plan to the carrier if they give you a written agreement that they're doing this audit. But on the self-funded side, still going to be liable. As a result, this will require some follow-up. Make sure that they're doing it. It may be an attestation or something. So information and documentation that will be really helpful when drafting this comparative analysis is any of your non-quantitative treatment limitations. So remember, these are your non-number limits. So look closely at non-number limits. We see a lot of concern in that area because it's kind of hard sometimes to measure and compare something that can feel very different. So you want to make sure you're looking at your non-quantitative treatment limitations very closely. So any documentation, including guidelines, claims processing procedures, or other standards that the plan might rely upon in the conclusion of whether or not that non-quantitative treatment limitation doesn't violate the mental health parity rules. Samples are helpful too. So if you have denied or approved claims, a sample of that will be good for you to review in your analysis. Sometimes having that real documentation in the operation of the plan. So for example, if you have a treatment limitation, see how it operates. It's one thing to have a rule that we are we have parity. It's another thing that it operates that way. So do a little sampling when you're doing your audit of the claims if you have that available to see if it is operating in a way that looks like there's parity, because that's something that the regulators will look at if I would say if hopefully if you get a request from the Department of Labor for a copy of the audit or for them to do an additional audit in general. So they're going to look at precisely defined factors and supporting sources on non-quantitative treatment limitations. So if this is standard for the industry, everyone does it this way, or there's a certain evidence that you can put forward that this is the way it's done, and it needs to be done this way for this qualifying important reason. Those are the kind of analyses that this audit is looking for. It's not a fun one. Look, it's not one check the box, you can move on kind of audit. It does require some reasoning and analysis and explanation as to, okay, there is a difference. Why is there a difference? Explain the evidence, the source, why it should be different, and why that this is acceptable under the mental health parity rules. So that comparative analysis is really what they're looking for. So we've written on this as well. We write on a lot of these things. So take a look at our articles that we've written on this. If you're not subscribed, again, please subscribe. I almost feel like I need to be like one of those YouTubers and point like and subscribe down here somewhere in my button, but I don't have a way for you to do it live here. But please subscribe if you can. This is how I communicate with you. And what we also saw this year was the FAQs come out, which provided some additional details for us on what they're looking for. We've also seen this congressional report, which is really quite interesting because it told us what we were doing wrong and what we were doing right as a group of people doing this audit. And I won't spoil it. I'm going to tell you on the next slide what that one looked like, but take a look at it. It's not too hard of a read, but if you're doing your mental health parity audit, you're about to, it might be a good place to start. Just kind of do a quick read of that, maybe with a glass of wine or whatever makes you relax while reading intense things. So take a look at that. So the Department of Labor is just strengthening the rules. They're strengthening the rules. In 2020, they say, please do this audit, please do this audit. And then nobody does it. And so the next year they're like, okay, for penalties, you'll get a penalty of $110 per day per plan participant if you do not do this. And then still not the congressional report comes out. And then we're hearing, oh, wait, okay, you're trying to do it, but it's not being very successful. So we're going to have some additional oversight. We're going to spend more time in mental health parity. So I'm going to talk more about what that congressional report looked like in a minute. But nearly all involved have a responsibility under mental health parity. So if you're a decision maker, if you're a plan sponsor, if you're a carrier, if you're a PBM, if you're a TPA, all of them have a mental health parity requirement, and all of them are people or entities that you should coordinate with in doing your own audit. So ERISA, non-ERISA, we're talking about everyone here. So there was a very small exception to the rule. It's not on this slide, it's on a later slide, but I'll give it to you now. But historically, up until this past year, small self-funded government plans could opt out of mental health parity, which was funny. And also most people didn't know about it, but I thought it was a funny rule to have. And considering the need for mental health parity that they were talking about, that we had this huge gap. So that was taken away. So now everyone has to comply with this comparative analysis. So if you were audited and you had incompletion or it was insufficient, you do have 45 days to correct the problem. So it isn't like slap, you're done, you're penalized. You do have a little bit of time to correct the problem before any other non-compliance penalty would come up, unless they found you were being egregious and really just trying to ignore the rules. If you're looking at doing this audit, and you know now that you have to get information from carriers, PBMs, TPAs, a lot of people have parts of this analysis for you. Let's say you're doing this audit yourself and you don't have all those players lined up. Start with the low-hanging fruit. Those carve-out plans usually have something in there that the Department of Labor doesn't like. Usually, carve-outs have exceptions in there that are going to be different. So start there. That's a good place to start analyzing or with your carve-outs, because we see some particular attention being paid there. So I hinted earlier, we have these 6 categories that they look at. So your dollar limits, those are the easy ones. Your quantitative treatment limits, those are pretty easy to identify because you're looking at the numbers, they either match or they don't. But those non-quantitative treatment limitations in each of those classifications would be important for you to look at. I'm not going to spend time reading the slide, but this just gives you a little bit more meat into the 6 classifications that we talked about on an earlier slide that they're going to be looking at in this audit. When you sit down and start doing your audit, or maybe you're going to go back to the audit that you started, just take a look at these definitions again to make sure we're looking at each one of these categories separately and comparing each one of these categories separately with the medical surgical side of your plan. So I alluded to, I was going to tell you about the congressional report. So the congressional report comes out and it says, no one did it right. That's essentially what it said. It said 0, nobody got it right. So I guess if we're all in it together, then we're all, no one should feel bad if you've struggled a little bit or not known something or not felt comfortable with this particular requirement. You're not alone. None of the comparative analyses that the Department of Labor received had sufficient information at initial receipt. So they had to go back each and every time and ask for the actual information that they needed. So they either failed to document the comparative analysis before applying or designing the non-quantitative treatment limitation. Think about it. So they really want to know what you were thinking and planning before you even applied the rule. And at this stage of the game, we're probably already operating under those rules. So it's hard for us to go back and analyze for them ahead of time. But you can get around that one. Conclusory assertions lacking sufficient supporting evidence or a detailed explanation. So it's not good enough that you just say industry standard, bam, that's my answer. Well, that wouldn't be enough. You would need to show evidence of that. So maybe you link to something, cut and paste something, show them a document, show them some evidence that that is actually what industry standard is. Failure to identify any specific mental health, surgical benefit classification. So maybe you didn't actually identify all of those non-quantitative treatment limitations in each one of those 6 classifications. It's easy to miss the non-quantitative treatment limitations. So pay very close attention to those. That is really what they're looking at in these audits. So these are just a few of the items of non-compliance that the Department of Labor told us about in their congressional report. So some of the things I would recommend that you look at when you're doing your mental health parity audits. The pre-authorizations, those ones always feel sticky to the government. Network provider admission standards, concurrent care review, billing restrictions or provider qualifications. So you can't even see that doctor unless they're qualified, right? And so making it hard to see a specialist, for example, in a particular mental health area, if there's too many restrictions on accessing a provider in that area, that would be a violation of mental health parity. Fail first and step therapies are always a little bit problematic. We see that more on the mental health side than we do on the medical surgical side. So for example, if we had somebody who had a substance use disorder, and we're requiring them to fail outpatient a bunch of times before they can get an inpatient, but you don't have something like that in the medical surgical. You don't have to fail physical therapy on your knee in order to get rehab inpatient. If that doesn't exist, then you can't really have it on the other side. And so you could probably sit here right now and probably think of some of these non-quantitative treatment limitations that you have in your own plan. They're in everyone's plans. It's now just saying, is there something similar on medical surgical? And if not, then why do we have it on the mental health substance use side? And if we do have to have it, we really want it, then we need to have a really good explanation, a sufficient enough explanation for why we need to have it and why it should be considered compliant. So take a look at this link to some additional words from the Department of Labor about how they're increasing oversight in the mental health space. I'm going to pause for a second, take a look at my chat, see if anybody asks me questions. No, everyone's quiet. Does anybody want to ask a question while I am looking at your faces? No? Okay, very well. I'll keep going. All right, next we're going to talk about privacy. So we're going to shift a little bit to some state stuff here. Privacy is ever expanding trend. It is spreading like a wildfire across the US. I live in California, although I'm based out of the Utah office. I live in California, so I am really used to privacy here. We have a really the most restrictive, actually, privacy law here. I'll talk about that in a minute. But our new latest ones are Montana and Tennessee. These become effective in 2024. You'll likely see this every year. The last, I want to say 3 years, it feels like there have been a minimum of 2 states that have implemented a consumer privacy rule. So if you're working in the employee benefits world, like I do, we're used to privacy in the area of healthcare, HIPAA, right? Now, these privacy rules generally will exclude all PHI, protected health information, HIPAA stuff, because they assume that you're complying with it where it applies. And there's also similar exceptions to these state privacy laws for Graham-Leach-Bliley, which is a financial institution act. So information that is private in those areas remain protected and private under those laws, but these state laws aren't interjecting themselves into it. Now, the thing about these 2 laws that are separate from the California one is that there are exceptions for employees too. So sensitive data that we're talking about here is not health data necessarily. It is PII, personally identifiable information. So sensitive information that's just on us individually, unrelated to our health. So these are really filling in gaps that privacy laws weren't doing yet. So state privacy laws are coming in and giving a broader privacy rule. A lot of them come with breach notifications. So if you had it, most of them say if you have a computerized system, and so some of them use computerized, like sounds really antiquated when we hear a computerized system. But let's say you have a computerized system and you have data in there and that's breached. There's usually a notification that comes with that. Most state laws say within a reasonable amount of time. Most states don't even give a time frame, unlike federal law like HIPAA that gives a 60-day time frame to notify. So a little bit looser, these state laws, than HIPAA or even California. But be aware that that is out there. I've linked to them as well. They're very new, so there's not a lot of sub-regulatory guidance on them, but they're easy to read generally as well. They're not very long rules. So the one I really wanted to spend a little bit of time on is California Consumer Privacy Act, or the CCPA. This one has been around for a couple of years, but this year became a bigger deal. And that's because there was a big exception to the rule on employee data. So any company that has an employee in California has employee data that is now falling under the CCPA. So if you have an employee in California, that's all you need for the CCPA to now be applying to you. Even you could be working out of Utah, like my company, and I live in California now. I'm making them have to be CCPA compliant when it comes to my data. But it's not just my data; it's all consumer data. So their CCPA itself is a massive rule, especially compared to other states. These states have loose time frames, very little meat. It'll just say, protect this. If it's computerized, you have to then notify. It's very, very light. Where CCPA has a ton of sub-regulatory guidance, a lot of definitions, a lot of exceptions to the rules where, okay, I have this PII data, but I don't actually have to allow that individual to opt out or to delete that data because we're falling into an exception that says I have to legally retain it, or for business purposes, I have to legally retain it, or it's actually information that's already available to the public. So there's a ton of exceptions and definitions. There's a data inventory map that's required to be developed if you are in California or California consumers or employees. The data mapping itself can be intensive. It's asking what types of information, name, address, social security number, driver's license, all the types of information that you have on a consumer, an employee, or an individual. Where is it coming from? Who's accessing it? Are you sharing it? And if you are, with who? Where is it living within our system? And how can you link to it so that if they're asking for an opt-out or opt-out from using my information, ask to request, delete my information, then you can link that information to the individual request. Then you have 45 days to, or 10 days to respond, 45 days to actually do the thing. So it's a much bigger rule, and it doesn't have an exception for employees, unlike all these other rules, which had an exception for employees. So you're now, if you're on any website for a California company, you're probably already seeing these privacy policies, opt-out buttons, a lot bigger banner displays. Those are all because of the CCPA. So if you are a company that's in California that has a California website, start there, because that's low-hanging fruit. Just like the American with Disabilities Act, when that was passed, we had attorneys going around and just checking people's storefronts for compliance. They are now doing that for websites. So we have attorneys here that are just searching websites for, is your privacy policy posted? Is there an opt-out button? Do you have the banner on the CCPA privacy language banner? And if you don't, then they sue. So that has already started happening this year. There's this website called blacklight.com. I'm pretty sure it's blacklight.com. You can go there, put in your website or anybody else's website, and it'll tell you some things about it. If you have Google Analytics, for example, then CCPA is probably going to apply, because Google Analytics by itself is taking some data and doing something with it on the consumer, with the consumer. So that'll be a good way for you kind of know what those attorneys that are out there ambulance chasing, essentially, what they're doing, what they're looking at in order to find companies that have red flags on their websites. So if you are a California employee or consumers or business with anybody in California, start with the website. We work with an employment law firm, Fisher Phillips. We have a good partnership with them, and they have a packet that they sell. I purchased it for my own company, so I know it's very good. That has the templates, that has trainings, that has your templates for your notices, because you have to send notices to consumers, your employee, your job applicants. So it'll have all of that. And they're a premier employment law firm that we work with. So if you wanted to be connected with them, reach out to your Leavitt Group representative, and we can get you connected to them so that you can get those resources in your hand sooner rather than later. We also had 2 other new privacy laws, one in Washington specific to health data here, and Nevada specific to health data here. They're also exempting anything that would fall under HIPAA, but sometimes there's a gap between HIPAA and what state privacy law would apply to protect that information. But if that health information, let's say, is coming from the employee, if I'm an employee and I am telling my HR person that I have cancer, I'm allowed to self-report that. It doesn't fall under HIPAA there because it has nothing to do with the health plan itself. This is an employment law issue where I'm telling them a health information. Now, these laws, these state privacy laws, will come in and protect that health information, even though it wasn't created or received by a covered entity. So it's just an extra layer on top of privacy laws that would generally protect information, identifiable information on consumer, and apply it to other health data that HIPAA may not apply to. So beginning next year, there will be an additional health law in Washington. If you live in Washington state, you're probably getting very used to having these types of laws come about. Washington is competing with California and becoming one of the more regulated, liberal, some might call, states. So we see things coming out of them a little bit sooner sometimes than us, even though people think California is probably the most likely to have these. Nevada is also coming up quick with their own stuff too. They seem to be regulating a lot, but so same thing. All of this consumer health data, you might get this in a lot of different places, but not necessarily from your health plan or your health provider. So any type of health data, it could be an app that you're using. If you have a Health Joy app, actually Health Joy would fall under HIPAA. I can't off the top of my head now think of one, but so there is a notice that is usually required at collection. So just like your notice of privacy practices that we use for HIPAA, there'll be a notice for all of these requirements. There's a notice somewhere. So either you have to post it or you provide it to the consumer or employee at collection of that data site. If you're doing, like for example, in California, if you're doing job postings online, you have to post the notice for CCPA online. If they asked for a paper copy, you'd have to hand it to them. So there's various ways that notices come into play, but they all come with a notice requirement. Some of these rules, like the one in Nevada and Washington, are new enough. There's not a whole lot of templates or anything's out there like that, unlike CCPA, which has been around a little bit longer. It just expanded this year to include more individuals. So we write about these as well. So take a look on the news.leavitt.com site. We have a ton of articles on CCPA that go into a lot of specifics. I know I didn't go into a lot of specifics with you today in the interest of time, but there's a lot of detail on our news.leavitt.com site. Speaking of Washington, let's talk about long-term care. So last year, beginning of this year, Washington Cares came into play, which is a long-term care program, the first of its kind in the States, began in Washington. And Washington Cares has been a clunky little thing. And so they've had a lot of mistakes. They had a lot of clunkiness. And as a result, other states that have already been on the pathway to implement a long-term care state program have slowed down a little bit. Now, what a long-term care mandate is if you're in a state, much like California and other states, Colorado, for example, there's a paid family leave program through the states. And so every paycheck, you get a little bit taken out of your paycheck, put into a state-run program that you can then dip into if you needed leave for your birth of your child. Same thing for long-term care. You pay into this fund, state-run, and then you can pull out from it whenever you need some long-term care to help pay for your wage replacement. So now the thing about these long-term care mandates is the employer and the individual, they can opt out of it. You can opt out of it if you have a sufficient private policy of your own. So in Washington, I think they were given, I want to say only 3 months before the effective date of withdrawing the money from the paychecks and putting it into the state fund. You had 3 months ahead of time to get a private policy in place so that you wouldn't have to comply with the state paying into their funds. That was such a short period of time that not a lot were able to take advantage of it. So California is next up. They've actually already been down this path. I'm actually going to pin that and do that next slide, but they've already been down this pathway a little bit. They started slowing down, looking at Washington so that they don't make the same mistakes. But California is not the only one. New York is likely next because they're already in the process. Minnesota is already in the process. So we're seeing a spreading of this long-term care mandate as well. So if you're in a state like California, especially, or New York, now is the time to be talking about long-term care with your consultants. So you and your Leavitt Group trusted advisors should be having a conversation now. Okay, what is long-term care going to look like for our demographic, our plan? Remember, it's not just for old people. Everybody thinks long-term care is for old people, but it can be for disabled young people who were in a car accident and have some long-term care issues until they rehab that knee. So we're not just talking about for elderly, so we should not get bogged down thinking about elderly demographics when we're talking about the need for long-term care. There's many states that are going to do this, so we need to sort of prepare ahead of time by beginning that planning process. So California, we already began this process last year, and there was a lot of promise that it was going to actually happen this year, but they slowed their roll, as they say, because things were messing up in California. There was a lot of confusion with the employers and the states. So they're here in California trying to figure out, okay, what kind of program do we want? There are different types of plans they could have. So they're trying to determine, do we want to allow, how much time ahead of time should we allow private policy so they can opt out of the state-run program? So they're trying to use Washington as a model, and so they're slowing down. So these timeframes you see on this slide are not accurate for future casting. They are for past tense. So we know that the task force is still meeting, that they're still drafting some proposals, and you might have heard, especially this year, maybe even very recently, from long-term care providers. So these are the carriers, those that are selling that long-term care product. You might be hearing from them that you need to do it today. Like, today is too late. You're going to miss out on your opportunity to opt out of the state-run program if you don't have it now. And the Department of Insurance here in California actually had to release a memo saying, stop saying that, because that is not true. We have no actual real law yet here in California. We are still in task force. So until we actually have something, you can't say, you better get ahead of it and do it now. We will let you know at Leavitt Group when this is really happening. We'll be ahead of it. We have a voluntary benefits department who stays on top of this, works very closely with the carriers as well on the long-term care side, so we can get you recommendations, referrals, whatever you need for a long-term care. We're prepared to start having that conversation with you, but there's no need to be an alarmist when it comes to what's happening in California yet. Transparency everywhere. I'm going to have to start talking faster. So plan transparency, this has been around. So you might recall a couple summers ago, it was machine readable files had to be posted, and they were machine readable, so you couldn't even really understand most of the time what they were posting. But your TPA, your carriers largely took the load of this, posted on their websites. Some of you had to post on your own, link to theirs that had all of the costs of goods and services. This online searchable tool now of an online searchable feature of where you can go in and search what it will cost for a good or service through your health plan. Now that has been expanding, and starting January 1, your plan year of January 1 and after, that is to include all goods and services. This year it had to be a list of 500 goods and services that they told us we had to have transparency around. And now it's expanded to everything. So lean heavily on your TPAs and carriers for this. get it in writing. Self-funded plans cannot transfer liability, just like with all of the other ones that we're talking about contracting with. Make sure that you read our articles on it. We had a few of them to stay on top of this. And this is the last one on plan transparency that we expected. So this is the big end. Everything's transparent now, but we are just seeing some less than full compliance all around. So I don't expect to not hear about this anymore. But just know, work with your TPA and your carrier to make sure that they are posting on that online searchable tool all goods and services. So that's something you want to coordinate with them on. Then we have service provider transparency. This is ERISA 408B2, and this is a compensation disclosure. We did a webinar on this last fall. So if you want a lot of details on this and pharmacy reporting, let me know. We have more stuff on this. But you as a fiduciary for an ERISA plan only are required to obtain from all of your service providers a compensation disclosure. This has been around for retirement since 2012, but they've expanded it to include health and welfare now, without giving us new rules or explaining the difference between apples and oranges of health and welfare and retirement, but rather saying good faith, go do a compensation disclosure. So now, if you've never had a contract with one of your service providers, but you're paying them money to help service your plan, now is the time to get one, because this requirement does require you to have a service contract with your service providers. Something that will show that will say what they're doing or giving you in exchange for that money. So there'll be a scope of services, ideally. It'll have disclaimers about probably, are they getting all the information, including from the COBRA vendor, the TPA vendor, or are they just dealing with their own? So it depends on the service provider, but it needs to have all of those terms. You need to understand what you're actually paying for. As a fiduciary, that's your due diligence to see what you're paying, make sure that it is fair for your plan participants. Now, the disclosure can be a formula. It can say, we derive this by 2% plus retention of 1%. It might be a formula because at the beginning of the plan, you don't necessarily know what you'll earn that year until the end. So sometimes it's a formula. Sometimes it will be a numerical value, like we get a straight 2% commission, that's it. It can vary, but just know that you are obligated to obtain from your service providers a compensation disclosure. If they do not provide that to you, there is recourse after 30 days. You can go to the Department of Labor. Prescription reporting is also called RxDC, which is prescription data collection. This started last Christmas time, so it's Merry Christmas. We've written on it. We've had a very large presentation on it. If you would like those materials, reach out to your Leavitt representative and we'll get that to you. But what to know about this is you're going to need to coordinate heavily with others. There's no way you can do it by yourself. Largely coordinating with your carrier, TBA, and PBMs. Make sure you're getting contracts with them if you are asking them to do the reporting on your behalf. Again, self-funded plans cannot transfer the liability, even if they have a contract, so they will need to follow up. Even if you're transferring liability and your carrier or your TPA is saying that they're doing it for you, you want to know, what are they doing for you exactly. On this slide, you will see that there are different files. There are many different files that are required for this reporting, and all of the green would be ones that you would get from your TPA or the plan sponsor. So make sure, are they doing all of these? Because there's a narrative file in there that most PBMs or TPAs will not do for you, because that narrative file might include things that they don't really know as intimately as you, like the cost of coverage, the tiers of coverage, things like that. So you want to verify with them exactly what part of the reporting that they're doing for you. All right, let's wrap it up with a couple of things that's important for you to take away. Gag clause prohibition. So this one says that there cannot be anything in the plan contract that would prohibit the sharing, the transparency of information. We see this a lot with lot with network providers that insurance carriers used to say, we can't release those contracts. It's proprietary. Well, that's illegal now. We need to have full transparency between network provider, carrier, participant. And so now there's a gag clause attestation requirement. It will be due beginning this year, December 31st, and then the same time every year. You will have to go to the CMS website and attest that your contracts do not have that. You can, again, ask someone to do this for you, do it by contract, self-funded, can't get out of it, but you can go down that route. These are active links that will take you to where you can do the attestation. We also wrote an article about it as well that you can see on news.leavitt.com. Our other annual adjustments, I'm not going to walk you through these, but they'll be helpful for you to have when you're doing your plan design for next year. And these are your annual adjustments. Most of these are resulting from having an HSA or a high deductible health plan, and then of course ACA. So I won't spend any time, goes up almost every year, so that's not a surprise. I want to spend 1 second on this one. So telehealth during COVID had a lot of laxity. So because we're all stuck at home, because we needed to see all of our doctors virtually, they had a laxity in the rule. You used to only be able to see a provider via telehealth if you already had an established relationship with them, if you were paying a copay, if you had a high deductible health plan. Now we see a lot of telehealth plans with no copay, which would very much run afoul of the high deductible health plan HSA qualifying. So now, though, we have 1 more year of this flexibility with telehealth. So they have extended through 2024 the ability to offer telehealth, first dollar coverage, no copay, across state lines with anybody. So you get 1 extra year of this. After 2024, if you have a high deductible health plan, then you need to be looking at what you're requiring as a copay so that they're meeting, they still have to meet their deductible. You're not going to get away from that after 2024. So you'll have to think about how you'll be impacted with a high deductible health plan. A couple more minutes, I'm going to leave you with some real quick state laws. California always has a lot, so I threw a few on here. I'm just going to mention them really fast. We have some articles on news.leavitt.com on some of these, so check them out. There's a ban in California on non-compete employment arrangements, so that's kind of been a hot one. If you have non-competes with your employees, you want to check out those articles. Unpaid leave for reproductive loss is new next year as well. So within 3 months of a loss of a child, including a miscarriage, they get unpaid leave. There's expanded sick leave from 3 to 5 days. If you're in San Francisco, there's a healthcare security ordinance there, which is a mandate to offer a certain amount of money towards their healthcare. It's kind of like a mini ACA before ACA. That amount of money changes every year. There's a schedule here. So check that out. Washington, Seattle has an ordinance for paid sick leave there, and they have a paid family and medical leave in the state that just like I was mentioning with long-term care, they have it with a paid family leave, and that gets adjusted a little bit every year. So this is your takeaway for today. So make sure you're checking that affordability percentage and work with your trusted advisor. Make sure all of your limits are in line. Make sure somebody's doing that gag clause attestation for you. It shouldn't be a difficult one to do, so I'd recommend you take a look at that. We do have a sample template of a language that you could, send to a carrier or others so that they can attest to you that they do not have those clauses. So we have something like that available. If you haven't received it from us yet, ask your trusted advisor for that. Don't forget your pharmacy reporting June 1st every year. Make sure you're getting your ERISA 408(b)(2) compensation disclosures from all your service providers. Make sure you're talking about long-term care now, especially if you're in Washington, California, or New York. Privacy regulations are spreading, so it's a good time just to have a robust privacy policy so you're not reacting to every state law. Comply with a restrictive law like CCPA, maybe not all of CCPA if you don't have to comply with CCPA, because it is rather robust, but parts of it, enough that you know that if another law comes about, you don't have to keep changing it. Your mental health parity audit's important. That one, the tool is there for you to use. It'll walk you through it. If you have any questions throughout your audit process, let us know. I'm here to help you. And then coordinate with your TPAs about air ambulance reporting in 2024. Let's try to get ahead of that and see, okay, who's going to do this for me? Can I get that in writing so that you can put that one to bed? When it comes to tracking compliance, I just wanted to mention that we do have a relationship with Compliance Dashboard. And even if you do not have a license or do not want one, that will help. The license would track every year, month over month, tell you what you need to do, remind you, give you some information. That's that dashboard ongoing monitoring. But what's free to everyone, every one of our Leavitt clients, we've negotiated a free gap analysis, if you will, or risk assessment, if you will. So it will be a compliance audit in general that it'll walk you through a questionnaire digitally, and it'll tell you where your gaps are. And then we can identify where you could use the most support. So that's just something to remember. We have that free resource here as well. I write a lot, so make sure you check out our articles. Here are some links, other links as well. We had an ERISA webinar, our foundation series on ERISA. We talked about plan documents and notices and COBRA back in August. So we have that presentation slides and recording available to you if you would like that as well. Just let us know. All right, let me check the chat. Okay, gag order prohibition, who is responsible for it? Everybody needs to do it. But on the fully insured side, you want to confirm with the insurance carrier, but everyone needs to do it. There is no exception. You can see a gag clause in self-funded, in TPA, and in fully insured plans. So I would take the attestation and the document that I drafted, and I sent it out to our internal folks recently, I think the last 2 weeks. I would take that, send it to the carrier or your TPA, have them read and sign it that they are attesting that they do not have a gag clause. And then that is where I would start. I would start there, and then secondary, then prepare for your attestation December 31st. Any other questions that I can answer for you today? I know I went over 3 minutes. I apologize. I talked fast. Okay, well, I hope to see you in our next series. We haven't scheduled 2024 out yet, but you will be seeing those coming up. We have these quarterly, and we'll talk about some foundational things, like things that we always have to comply with, and sometimes we might forget a little bit about certain specifics in the rules. So I'll be focusing on that, and then every end of the year we'll do an annual review like this, where we can prepare you for next year. So I hope you found today to be helpful. I hope you were reminded of some things we needed to do and maybe learn some things as well. We'll send you that follow-up email. And if there's anything else that I can do for you or any of us at Leavitt Group can do for you, please reach out, let us know. We're here to help you. We are a part of your team. And have a happy Thursday.